what we'd say in medicine is the conservative side, which is the medical side. Now we're going to talk about the possibility of intervening and reducing post-thrombotic syndrome. And we have a team here, do we? Do we have?
We've had quite a busy weekend, so my colleague might be stuck in theatre dealing with a patient. So I may give the whole talk, or we may swap halfway through, depending on how we get on.
So these are my wonderful colleagues. I hope we see the second, Mr. Stephen Black, who's our new vascular surgeon here at Guy's and St Thomas. And we also have Narayan, who's the most amazing intervention radiologist and who works with the vascular surgeons. Well, no, I'm going to let him explain.
Okay, thank you, Prof. It's a pleasure to be here. As Prof explained, we've set up a dedicated venous multidisciplinary team, which includes our vascular surgical colleagues, our excellent thrombosis team, and us in interventional radiology. And for those of you who don't know what interventional radiology perhaps do, it may become apparent with some of the slides I'll be presenting later on. So in terms of what I'm going to cover in my part of the talk is just go through again what post-thrombotic syndrome is, why it occurs, what we can do to prevent it, and go on to discuss when we treat post-thrombotic syndrome with the means that we have at present and how this treatment is done. In terms of post-thrombotic syndrome, this is what we're talking about. It's a spectrum of symptoms as described on there: pain, discomfort, swelling, going on to the more extreme versions, which are ulcers and rashes, which occurs after a thrombotic event. And these symptoms that present are often worse after periods of standing, walking, or sitting. This is quite a common problem, and one of obviously the reasons why we're here is to increase awareness of this issue. It affects a lot of people after a thrombotic event, up to 60%. Some studies even say greater than that, maybe up to even 75%. And up to 10% of patients go on to develop the more serious versions of it, which is venous ulceration. And not only is this a cause of morbidity for the patients, it carries with it a large economic burden for those of us treating it. And this is a sort of spectrum of issues that we are hoping to, prevent, and when they do occur, treat as best we can. So typical sort of pigmentations that occur on the leg are shown up there, and skin hardening going on to sort of ulcerations and perhaps healed ulcers. In terms of what causes this to occur, as we know, thrombosis is the single most important reason. This affects up to 1 in 1,000 patients in the UK every year, and this translates to about nearly 60,000 new cases. And the morbidity and actually the mortality of thrombosis-related issues has been epidemiologically studied, and has been attributed to greater than that of the three big issues that are over there. And in terms of what causes the thrombosis, we've discussed this very important person whose birthday it is today, and it's a triad of features which results in the formation of thrombosis. The first factor which predisposes you to this is anything that causes the blood to become thicker or more stickier than usual, and this may be because one is on the oral contraceptive pill or on hormone replacement therapy, or other factors that lead to the blood becoming more sticky. Anything that causes the blood to not flow as freely as they should do, immobility, for example, increases your risk of a thrombotic event happening. And together with anything that causes the lining of the vein to become affected, either because of previous surgery or previous injury, predisposes you to the formation of thrombosis. Now, a lot of clever people have done some extremely important and excellent work at understanding what happens at the level of the cells to cause the blood to form clots, and what results in the propagation, i.e. the clot to sort of propagate or move up the legs. But in terms of what's important for us as those who are treating it is what happens after the thrombus forms. Now, for the thrombus to resolve and to the vein to go back to being normal, a number of things need to happen. Once the thrombus needs to organize, and one needs to have the vein that becomes recanalized, i.e. allows the blood to flow freely through that segment of vein again. And the veins in the legs in particular have these important structures called valves, which allow the one-way flow of blood up the legs to prevent gravity having an effect, making the blood go the other way. And so once the process of thrombus resolution, importantly, has the needs to make sure that the valve function is restored completely. When you have any failure of these three aspects of thrombus resolution occurring, that's what we believe results in the development of post-thrombotic syndrome. So current treatments, as we discussed earlier on, focus on preventing the thrombus propagation and preventing or lowering the risk of pulmonary emboli or of recurrent DVTs occurring. And the reliance is then on the body's natural means to dissolve the thrombus that's already formed. Now, this is completely fine if your clot is located below the level of your groin, so it affects your leg mainly. But once you have a lot of clot forming, as it occurs in a minority of patients, a small proportion of patients, when it extends up above the groin, up into the pelvis, what's called iliofemoral DVT commonly, then there is a potential for the thrombus resolution mechanisms within the body to be overwhelmed by the sheer volume of clot that's present. And when you fail to resolve this can result in the vein becoming scarred or even blocked or stenosed, and the valves being damaged also. And this is a pretty extreme example of a patient who presented with quite a large volume of thrombus. And here, the thrombus, pointed out by the arrow, extends right up to pretty much up to about the upper abdomen. So in this sort of scenario, it's very difficult for the body's own mechanisms to cope with sort of dissolving away this volume of thrombus. In the early days of venous clot surgery, the way of dealing with these clot was to open up the veins and physically remove the clot that was present within the veins. And in early studies, this is going back to 1997, even doing these forms of relatively major operations resulted in improved venous patency and reduced incidence of post-thrombotic syndrome. However, these surgical procedures are not easy to do, and they do carry their own risks also. And so things have now moved on, and what we now, a very good way of treating these now is the use of clot-busting medicines or thrombolysis therapy or catheter-directed thrombolysis. And the way we do this is through a very small little nick in the skin that we make, often behind the knee, and we place up a little catheter which goes into the vein where all the clot is, and through that catheter, we infused a special clot-busting medicine called tissue plasminogen activator, or also called catheter-directed thrombolysis. And what this medication does is it physically dissolves away the clot that's already in the vein, helping the body's own mechanisms to dissolve the thrombus. And this is a typical patient that we treated. This was a lady in her early 40s who was an actress in the West End who presented with a very swollen leg. And post-thrombotic syndrome in her case would have been devastating because she spends a lot of time on her feet. And with use of these clot-busting medications, we were able to establish good flow going through that vein so that her leg reduced in swelling quite dramatically over the first 24 hours, and she was able to go back to work within a week. And I think this comes back to a comment that I'd like to make, perhaps based on the previous lecture also. In patients who've had deep vein thrombosis forming, in our opinion, it's very important to be able to mobilize very early. It seems counterintuitive to keep them in bed for 2, 3, 4, or 5 days. We want to be able to get them, treat them, and get them back on their feet and out of hospitals for many reasons, but most importantly, if the patient's presented with a thrombosis event in the first place. But perhaps we could discuss this later. In terms of further on, often patients who present with quite proximal thrombus or iliofemoral DVT have an issue with their veins quite high up in their pelvis. And in this regard, you may have heard of terms called Thirdness Syndrome or Cochrane syndrome, which is essentially the same thing. And what happens here is, in all our bodies, this is the arrangement of the red structure, which is the artery, and the blue structure, which is a vein. And there's a very definite focus point where one of the arteries crosses the left common iliac vein, and you get this sort of appearance to the vein here. And as you can imagine, compared to the vein that's sitting next to it, when it becomes compressed like that, when blood flows through it, you get turbulent flow, and you get a fibrous reaction within that vein, and this propagates the formation of these large volume thrombus. So when we're treating the patients with this sort of thrombus, it's important to not only clear the thrombus, but often deal with that compression point or the Thirdness point with placements of dedicated metal structures called stents. And the stents are essentially internal struts that keep the vein wide open to allow a good column of blood to flow through that segment of vein. And in terms of the evidence for the use of these clot-busting medicines, there was a very good Cochrane review, which is essentially a review of a number of studies. And this particular one took into account 17 randomized controlled trials, which are multi-center trials involving a total of over 1,100 patients, and looked at all forms of clot-busting treatments. Now, we would usually only advocate the use of catheter-directed thrombolysis because that's giving the clot-busting medications directly into the thrombus where it needs to work. Whereas systemic thrombolysis, although easier to do, involves the clot-busting medicine going all over the body, which may have some more hazards to consider. So despite this being taking into account all forms of treatment, they found that by giving this lysis treatment, you reduce the incidence of post-thrombotic syndrome 5 years down the line, 10 years down the line by a significant amount. So in terms of our strategy for preventing post-thrombotic syndrome, yes, they need to be on anticoagulation therapy. We heard that compression stockings are controversial, and we take that on board, but particularly for large volume proximal iliofemoral DVT, we would highly recommend the use of catheter-directed thrombolysis in those patients who are considered suitable for that. And it's important to not only treat the clot, but to go ahead and treat anything that might be predisposing you to that clot-forming process, like the Thirdness syndrome. Okay, so I'm just going to look to see if my colleague has joined us, and he's not going to join us, so I'm going to carry on and sort of make up the rest as I go along. So as I said before, the consequences of venous thrombosis is that it results in damage to the lining of the wall, vein wall, which results in that vein becoming scarred or even blocked. The second consequence of venous thrombosis is that it can damage the valves in the veins, which can result in the valves not doing the job, which results in sort of the blood not being returned to the heart effectively. And it's a combination of this that results in post-thrombotic syndrome. However, in individual patients, it may be one which is a more dominant factor compared to the other, and in a different patient, it may be the reverse. So every patient needs to be considered in a individual basis. And these are the sort of veins that we see in the leg. And in terms of deciding those patients who would benefit from having their post-thrombotic syndrome treated, we use imaging to guide us. In essence, patients who have blockages in their veins, in their pelvis or above the groin do very well from stenting procedures that could open up the veins. But those with blockages below their groin don't perhaps do quite so well. And certainly, in patients who have leaky valves in the superficial veins, do very well from treatment compared to deep venous reflux. And I'll just go through that again in a little bit more detail. This is a typical patient that we treated in our practice in the last year or so. She was a lady in her late 40s we're a big lupus center here, so this patient had systemic lupus erythematosus and antiphospholipid syndrome. She'd had 3 previous DVTs affecting her left leg, and she was on warfarin and compression stockings. Despite that, she complained of significant post-thrombotic syndrome. And this is what we do to help us decide if this patient is suitable. These are images from an MR venogram. Now, there are various ways in which we can look at patients, but this is an imaging modality which doesn't involve radiation, doesn't involve any contrast administration, and it only takes about 10 minutes to do. And it gives us beautiful pictures of exactly what we need to know and mapping of the veins that we see in the body. And this here shows a very nice big vein, which is a normal, healthy vein called the inferior vena cava, quite high up. And as we come down, if I stop there, this on the right-hand side is a normal, healthy vein, whereas here on the left is a very scarred left common iliac vein, the result of previous proximal iliofemoral DVTs. And this is down here, down in the groin. Also, you see that being a normal vein, and this is a vein which is significantly scarred. And what we do, and this is what I do as an interventional radiologist with my colleagues, is we go into the vein through little incisions like I showed you behind the knee or in the groin or in the neck, and we put up a little tube called a catheter, inject some dye, and we see these scarred veins in the pelvis. And what we can do quite nicely is to place these stents which return the size of the lumen of the vein to its normal size, allowing free drainage of blood up through that segment of vein. And in terms of the results of stenting to treat post-thrombotic syndrome, one of the largest series was published in the US of over 1,100, in this case, 982 cases. And they found that going ahead and treating those patients with obstruction, without reflux and with reflux, they had very good results. And I'll go through the results in a moment. So focusing away from when the vein becomes scarred and blocked and stenosed, the other thing, like I said, that can happen is the valves in the veins can become damaged. And now that can affect both the deep veins, which are the sort of veins deep within the legs, or the veins on the surface of the legs, or the superficial veins. And when the superficial veins become affected, you can get these big varicose veins, in essence, forming in the lower leg or over the thighs. And what one can do to treat these is to put up these catheters, like shown over in this image over here, which has got a radiofrequency probe at the end of it. And in essence, what one can do is by drawing it back, we can burn those veins on the inside. Now, it sounds like it's a painful procedure, but this is actually a very painless procedure. It's usually done under local anesthetic. It's a day case. The patient comes in the morning, has the procedure done, and is often gone home at lunchtime or early afternoon. And that can result in these varicose veins disappearing to give a very good sort of cosmetic result, but also, importantly, a functional result. But importantly, this form of treatment is only appropriate for superficial venous reflux. It's not indicated for deep venous reflux. Again, imaging that we do can differentiate between the presence or absence of the two forms of treatment to guide what we do. And going back to the big series that was published, even in patients with very severe venous ulceration disease, treating the venous obstruction with the placement of stents and treating the venous reflux resulted in very good results, complete venous wound healing in the majority of patients compared to standard treatment. I'm going to finish or go over in the next 5 to 6 minutes a few other case examples of what we deal with. This was a young lady in her late 20s who presented with terrible post-thrombotic syndrome of her right leg. And in essence, this is what we deal with here. The veins in the groin here are good up to the groin level, but beyond that, there is the standard, the common iliac vein or the main channel is blocked, so the blood then has to struggle to get back up through these big collateral veins which don't do the job as well as the standard vein does, but secondly also gives a very unsightly appearance of these veins forming on the anterior abdominal wall, but also in the pelvis. And by restoring flow, what one does is places a stent in, which lets the natural direction of flow to be restored with a complete obliteration of those collateral veins that were forming. This is another lady. This lady was much younger, in her, I think, late teens or early 20s, again with very scarred veins which should be running straight up her leg here, but instead of because of the presence of the scarring, there were these large veins that meant that the blood had to find other means of tracking back up, placing a lot of pressure in that leg. And by going in and treating this by placement of stents through a minimally invasive procedure, you're able to reestablish the flow of blood up the natural channel of blood so that blood can return much more freely, taking away the pressure which gives you the post-thrombotic syndrome in your leg. So in conclusion, I'd like to say that there are ways of reducing the incidence and the severity of post-thrombotic syndrome. It's by no means a perfect treatment. We are learning as we're going along, but certainly in a group of patients, it has been shown to work very well. And even in the presence of post-thrombotic syndrome, deep venous reconstruction can contribute to symptom improvement. Thank you very much.
Thank you very much. It's very clear. Lovely pictures. I'm sorry your colleague couldn't make it, but the realities of life creep in. Questions? Oh! Hello. Do you want to come to the front? It's a crafty move to not arrive to the end of your talk. Come have a seat, Stephen. So this is Mr. Black, who should have given the talk.
You did a good job. I couldn't.
Yes. So questions for these two.
Okay, I've got a question. Oh, sorry.
Yep, go for it. Yeah, with a mic.
My name is Brigitte Marston. I've got a question. It's really regarding when you put one of these stents in, how long do the patients have to stay on anticoagulation for?
Yeah, so our local policy is if they're not on anticoagulation already, they would go on 6 months of our therapeutic anticoagulation. And the reason for that is these stents, although they go in and they're metal structures, within about 6 weeks to 2 months, they become fully endothelialized within the wall of the vein. So if you then, after that period of time, if you look at the vein from the inside, what you will see is normal vein wall. You wouldn't see the stent anymore. But, as a precaution, we would always put patients on 6 months worth of therapeutic anticoagulation.
Thank you.
Just a sec, there's a microscope for you. Oh, it's the same question.
The same question.
I think just to caveat that, 6 months is the minimum, and we don't know for everybody. Everybody's different, and I think at the moment there's no data to guide us on when to stop anticoagulation with venous stenting that's sufficient numbers. So you have to be prepared if you're going under a venous stent that you may need long-term anticoagulation. You can't make a decision based on having treatment that it can come off anticoagulation in 6 months. That may not be the case.
Can we ask who should be referred to you?
Yeah, I think post-thrombotic syndrome is such a common occurrence after a thrombotic event that I think anybody who has a history of a DVT, who has a swollen leg, potentially and/or all the other symptoms, pain, warrants referral for consideration of treatment. Now, that may seem like a lot of patients, but I think what we've got better at is to use screening imaging tools to determine who would benefit from the type of treatment that Steve and I do. So we're able to, immediately sort of go through and figure out which patients do best from this form of treatment. So the answer is anybody who's got a swollen and/or painful leg after a thrombotic event, which is greater than, I think if I may just add to that, I think anybody who has an iliofemoral DVT, who presents acutely with an iliofemoral DVT, warrants consideration of thrombolytic therapy, because we've seen that those patients do the best. Failing the acute presentation, I think you wait for 6 months, and if they develop those symptoms, I think they warrant referral.
And if we would send you all our patients with post-thrombotic syndrome,
You do.
which we do, what percentage can you help?
I think we found that particularly patients who've had an iliofemoral DVT, where at least 30 to 40% roughly of the patients are deemed suitable for some form of venous intervention, venous surgery, I feel.
Stella.
Steve, do you have anything to add to that?
So I just want to say, in addition to that, we have to remember that there's not only stenting as an option for patients. So we've started with stenting because it's the most straightforward, technically, with the least potential risk for the patient out of the things we do, but there are obviously risks attached to anything we do. You can escalate through surgery, and what we're trying to do is explore which patients would benefit from surgery. The difficult thing is, if you don't have enough blood flow coming up your leg to keep a stent going, the chances of it working to keep an operation going is pretty poor. So there's a lot of decision-making paradigms that you have to go through, and I think it's important to be pragmatic and realistic. It's not it doesn't cure everybody. It's something we're trying to develop.
Stella.
I just want to know up to how long after an acute clot can you do these stents?
Yeah, so I think I think it's most important, if possible, to treat the patient with the acute DVT during the acute presentation. So within 14 days is the NICE guidelines for the treatment of the acute deep vein thrombosis. Now, if you're outside that 14-day window, up to 3 to 4 weeks, you may still benefit from having the acute treatments to remove the clot and treat the underlying stenosis. But if you're beyond that 3 to 4 week window, then it's recommended that you wait for 6 months to give your veins a chance to recover or form alternative channels below the groin, to then help you with the treatment that you may do above the groins. So you have an acute window, which is usually 2 weeks, but maybe up to 3 weeks. But outside that, it's 6 months and beyond.
Yeah, it's the same question, really, because in places like India, where they're petrified of anticoagulants, they'll do this acutely. And by acutely, I mean as they present.
Yeah.
I'm just wondering why we're not being as aggressive as that, really.
I think there was a very interesting study that came out of Nottingham, which looked at the patient, looked back retrospectively at the patients who presented through their acute service with acute deep vein thrombosis, and those who would have met the criteria for treatment of deep vein thrombosis. And they found that it was only about a third of patients who were suitable ended up having that acute treatment. So I think that comes down to awareness and the sort of the logistics of how it's set up within the hospital. So I think in that respect, having a protocol that's set up which sets out exactly the treatment pathway that the patient takes is very important, and having all healthcare professionals who deal with deep vein thrombosis aware of these forms of treatments is important also.
I think that we want to move towards that. I think there's no doubt that we're seeing benefit from early intervention as a pathway. We've spent 20 years maybe not looking at this as a pathway, and we're changing all that mindset and perception and so on. It takes a long time, and you have to have success in your hospital, you have to have success with patients for people to believe in it, and we have to have evidence to really support a big move away. And I think that's where we're different from India, where I know a lot of the thrombectomies are done.
Any more questions? Last one. Thank you.
Yeah, as a man defending medical management, I'm going to be a bit confrontational with you now. Okay, so this May Thurner, okay. Now, is it not true that everyone has a little bit of compression of the vein with the artery? That to some extent, we've all got a bit of it. Because that's what our interventional radiologists tell me.
Yeah, I think it comes back to how you diagnose these compression syndromes. Yes, it's true if you just look at cross-sectional imaging, which if you remember you do with the patient lying flat, and it's a very artificial scenario. If you look at that point, it may appear that the vein is compressed between the artery and the vertebral body. However, as we do in our practice, the true way of knowing if it's really a Thirdness syndrome is by having a look at the vein from the inside with a device called intravascular ultrasound, which really gives you a very important way of looking at the veins, because you see the vein sort of moving with respiration, and you see where the artery crosses it, and you see that vein being compressed like flat as a pancake like that. So it comes back to how you diagnose it, because you can overdiagnose it if you use the wrong imaging modality to do so. But if you use an appropriate imaging modality, Thirdness is a very definite phenomenon which you can exclude or diagnose based on imaging.
Yeah, and it's loaded because we do see quite a few people who stop their 6 months of anticoagulation and they've had stents put in and the stents just clot within a week.
Yeah, yeah.
And so has there been a randomised study for people with possible Thirdness syndrome looking to randomise between medical therapy and stenting? Because I'm a bit worried it might go down the route of IVC filters that we chuck in all the time without good evidence.
Yeah, I think... shall I take it?
There hasn't been a study, and the only two studies that are out at the moment for lysis are the Cavan study that came out last year and ATRACT, which is due to complete, that are genuine randomised data, and they're quite different. We don't know.
They're thrombolysis, aren't they?
Yeah, thrombolysis.
Yeah.
So those are the only two randomised studies looking at anything, and you extrapolate out of those which patients seem to benefit from a stent. I think that the answer is we don't know. We can't select on hemodynamic bases which Thirdness lesions are significant, which are not. All you can do is take a patient who has had a DVT, and it's often a combination of things that provokes that, and look for a provoking cause, which may be a Thirdness, and treat it if it seems appropriate. I think that's the future. We have to understand where you are. I agree with you completely. We don't want to be treating every single person who has a Thirdness lesion with a stent. We want to be selecting out those who will benefit most. And there is not enough data at the moment to give us any robust guidance on that, which we really have to be cognizant of when we are treating patients.
Thank you very much, gentlemen. Thank you so much for appearing as well,
Sorry,
Stephen. It's very kind of you. Thank you.